One of the great things and privileges that I noticed when I came here as chair of the Department of Surgery was what a rich collection of endowed professorship visiting lectureships that we were privileged to have here. And it's also been a great joy to have the Battistella Lectureship be our inaugural lectureship of the year. So for our new trainees and our residents, it really is an honor, and in particular, to celebrate Dr. Battistella's life and legacy. He was a beloved UC Davis lifer, a trainee here, up and coming rising star in the trauma world, who tragically died at a very young age of metastatic cancer. And so it is with special gratitude that we kick off our series of visiting lectureships with the Battistella Lecture every year. And I'm particularly excited to have a great visiting professor this year. And I will turn that introduction over to Dr. Calcutt.
Thank you. Well, thank you all so much for being here. As Dr. Farmer said, this is a deeply meaningful lectureship to our division and to the department. Dr. Battistella, who I unfortunately never had the privilege of working with or knowing, means a lot to many of the faculty who are still here. And as Dr. Farmer said, he was lost to us at a very young age of only 48 years old. So after having spent 22 years here. So every year we use the opportunity to bring a nationally renowned speaker here to talk to us about something that's important and would be important to Dr. Battistella. He was a consummate educator and always interested in helping people be better at what they did, in addition to excellence in patient care. So I'm very pleased and honored to be able to welcome Dr. Kimberly Davis here to be with us. She's currently a professor of surgery and the chief of the Division of General Surgery at Yale School of Medicine in the Department of Surgery. She also serves as the System Trauma Medical Director. She has a fantastic legacy and career, and she's going to talk to us a bit about that. She currently is our American Association for the Surgery of Trauma, AAST, current president. She has previously served as the president of EAST and is on a member of the executive committee as the for Western Trauma. In addition to all of that, she has been a prolific author and has written more than 200 papers, as you can see on the biography that's provided in the handout today. But more importantly, she's been a mentor and a friend to many of us in this room over the course of her career. And I'm deeply honored that she accepted our invitation to come and literally fly all the way across the United States. For those of you who have never been to where Yale is, you can almost not get further away from California. And so I'm very appreciative, especially just a few weeks before her presidential meeting for AAST. So it's my great honor and privilege to welcome Dr. Davis.
Well, good morning. Everybody awake? I woke up at 4 o'clock. I'm still on East Coast time. How do I go? Never mind. I'll figure it out. So it is my great pleasure to give the Battistella lecture. I just want to highlight some of the things that Dr. Farmer said, and thank you, Dr. Farmer, for the privilege. He was described as someone with unselfish dedication who provided compassionate care, a highly skilled surgeon. And for those of you who want to assume leadership roles in surgery, you really have to walk the walk and talk the talk. So you need to be in the operating room with your faculty and with your trainees. Again, kindest, most compassionate, highly skilled, great teacher, passion for teaching and mentoring. And all of that was recognized by the UC Davis School of Medicine. He got a Distinguished Alumni Award, an Outstanding Resident Teacher Award, an Outstanding Chief Resident Award, a Friends of Nursing Physician of the Year, an Outstanding Faculty Member in a teaching capacity, none of which I've ever gotten. So obviously an amazing gentleman. So when Dr. Calcutt and Dr. Kokenauer, in full disclosure, Chris Kokenauer and I have been friends since dinosaurs walked the earth, asked me to talk, I'm like, well, what kind of talk do you want? Do you want me to stand up and talk about something that is new and different in trauma? Do you want me to talk about emergency general surgery, which happens to be my passion? Thank you for whoever presented all the stuff on diverticulitis. Um, or do you want me to talk about the things that I've done wrong and demonstrate to the people in the room that you can have multiple errors in your career and still be successful if you identify ways in which to correct either your behavior or your errors? So this is going to be a kind of a therapeutic talk for me. I hope you all don't mind. We're going to talk about charting a course, and that is my brother's boat. I have no disclosures other than I'm a fanatical kayaker, and I love living on the water. So I would never live in Sacramento because you all are not on the ocean. Sorry, but the vineyards are pretty cool. And my objectives are to describe some key lessons that I've learned, one from clinical practice, but mostly in leadership and professional development, and to really discuss some strategies for navigating the changes that we are seeing in academic surgery as surgical care delivery becomes more corporatized. And finally, to reflect on the importance of mentorship, sponsorship, and lifelong curiosity. So lesson 1, and this is Elsa. How many of you have small children who have watched the movie that Elsa is in? Frozen, I believe it was called. Let it go. So the goal behind this is to emphasize the need to preserve your energy for what you believe is valuable and actionable. And what I will say about our personas as surgeons is we are all type A. We did not get through grade school, high school, college, and medical school without being aggressive, attentive to detail, somewhat of a perfectionist, and basically driven. Anybody in this room not driven? Right? So what attracts us to surgery is the achievement orientation, the competitiveness, the confidence that we need to deliver care to people who trust us to cut them open. Our risk tolerance, which is higher in some of us than in others, and our locus of control. We make high stakes decisions. We live in an environment, particularly the ACS folks, that is time pressured. We want to do the right thing. We want to be perfect, although perfection is often the enemy of good. And we take ownership of our patients. But what that very behavioral structure paradigm that you all have can be perceived as, particularly if you are female, disruptive, intimidating. Apparently I'm scary, who knew? And difficult to work with. So this is a book that somebody gave me when I was a wee junior faculty member. It's a great book by Marshall Goldsmith called What Got You Here Won't Get You There. And I encourage everyone in the room to read it because this is how to take your type A personality and function in the environment that you are going to be required to function in. And some of the things that you need to let go are the need to win. You cannot challenge every decision. You have to compromise. My own personal favorite, and I do this all the time, is adding too much value. I have an opinion on everything. What are the odds? An opinionated surgeon. What you need to realize, though, is not everybody cares what your opinion is on everything, and that you ought to be careful about what you opine upon and try to avoid interrupting, correcting, etc. The next thing I'll comment on is we are all smart, and you may actually be the smartest person in this room. I know I am. Joking. The problem is that you cannot always demonstrate how smart you are because you come across as extremely arrogant. You need to avoid passing judgment, particularly in public. Those are inside voices. And for those of you who encounter things that make you angry at work, step away. Do not respond to that email. You can type it, but put it in your draft folder, or more importantly, type it so that you spew out everything that's annoying you and then delete it so that it doesn't accidentally get sent, because Technology is sometimes a challenge. Behaviors rewarded in the operating room are not always the best behaviors that produce the best outcomes in leadership. So what is a disruptive physician? Well, there are three things that we can do to be disruptive. We can have a lot of interpersonal conflict. We can yell. We can be intimidating. We can be verbally abusive. We can publicly humiliate people. Probably not a great idea. You can demonstrate disrespect. You can have disruptive professional behaviors, repeated noncompliance with protocols, chronic lateness, not answering your phone when somebody's looking for you, or you can have safety-related behaviors. And all of these are falling under the category of disruption. Interestingly enough, the most common trigger for disruptive behavior, 90% of disruptive behavior is triggered by the environment. And there was a paper written by a woman whose first name is Claudia, whose last name I cannot remember, back in the late 90s. It was a phenomenal paper that looked at all of the surgeons that were reported as disruptive in a very large healthcare system. And she noted between 90 and 95% of the behaviors were triggered by something in the environment. So you have to be very careful about being triggered. A lot of it can be inadequate OR team familiarity. I know my surgical oncologists have their scrub and their circulator. My vascular people have their scrub and their circulator. I get whoever isn't busy. And inevitably, it's the person who has never put the little stapling device in the stapler, so that you have the pleasure of educating the person who should know more than you do. But it can also be triggered by lack of standardization, equipment or resource limitations, and fragmented care transitions. All of it contributing to a high-stress environment and all potentially triggering what is perceived as disruptive behavior. The other 10% are physical things. You're getting older, you have some cognitive or neurologic decline. We work in a high stress environment, and some of our colleagues are either addicted to substances or take medications that may negatively impact their behavior. And then there is the standard, we don't take enough care of ourselves, so we have emotional exhaustion, physical exhaustion, and cognitive overload. Do you all realize that when I was a resident back when dinosaurs walked the earth, medical information changed over every 7 years? Medical information is changing over every 18 months now. We are totally overwhelmed by the volume of data that is coming into our poor little brains that we have to process. Cognitive overload. So I have some thoughts on letting it go. The first is take a deep breath, and you'll hear that again towards the end of the talk. We all need to receive feedback without resentment. And as we get a little bit later into the talk, I'm going to talk about the importance of professional coaching and 360-degree evaluations. For those of you who don't know what a 360 is, it's the people above you, the people that at your level, and the people who are lower on the food chain than you are, giving you feedback on how you behave or what you are perceived as doing. And that feedback can be extraordinarily useful and absolutely devastating. So if anybody gets sent for a 360, realize that you're probably going to cry when you read it, unless you're a man, and then you just kind of sniffle a little. Another thing that I've learned is restraint is a marker of maturity, and I'm approaching Medicare. I have a really good esthetician. I'm still learning restraint, obviously. Comparison steals satisfaction. So when I was a junior faculty member and I looked at all the women that are now my closest friends in the world of trauma and acute care surgery, I would look at them and say, oh my God, well, she can do that and I can't. And it made me feel lesser. You do not want to compare yourself to anybody but yourself. Finally, it really doesn't matter what other people think, and you really need to let go of resentment. I put this slide up here not because I want everybody in the room to memorize what the H indices and the Google Scholar indices are for assistant, associate, and full professor. What I will say, though, is your success will be determined only in about 5% by the stuff on the left-hand side of the screen. Your professional experiences, showing up and doing the work, 15%, but 80% of what you are going to do and how you are going to be successful is going to be your communication skills. And nobody teaches us how to communicate in medical school. So we all need to learn a little emotional intelligence, which is the capacity to be aware of, control, and express one's emotions in a tempered fashion, and to handle interpersonal relationships judiciously and empathetically. What that requires is self-awareness and knowing what your triggers are. You need to have empathy not only for your patients, but for their families, your colleagues, and yourself. And you need to have self-regulation. And self-regulation is really hard after a night on call when your frontal lobe is in charge. So if you're tired, be extra careful. The other thing that we deal with as surgeons, and I'm not saying it's just us, it's probably everybody in medicine, but we deal with adversity. We deal with complications that can be life-threatening. We deal with litigation. We deal with professional relationships that may or may not be fulfilling and pleasurable. We need to figure out not how to avoid adversity, but how to respond to adversity. And my first comment is going to be ask for help, which is going to be another theme of this discussion. You do not want to suffer in isolation. So if you are having a particularly bad day, find a friend and talk to them. They will often talk you off the ledge. More importantly, they will tell you that they have had a similar experience at some point in their lives and you are not alone. Because the first time you get sued, you think you are the only person on the planet who got sued. You're not. The other thing that I found extraordinarily useful is asking myself, will this really matter in the long run? Am I going to care about this in 6 months? And if the answer is no, let it go. While you can't always change what other people are doing around you, you can control the way that you respond to it. So this is me talking to myself. You really need to be able to control how you respond to people. All right, lesson 2, less is more. We're going to do a little bit of clinical stuff here because I am an acute care surgeon, and then we're going to talk about less is more in leadership. There's been fundamental change in the management of solid organ injuries, even though we still operate on every hemodynamically unstable patient. Non-operative management, and I don't call it conservative management, Dr. Farmer. It is non-operative management, and is often not conservative, has become the treatment of choice for stable patients. Decreased abdominal infections, decreased transfusions, they go home faster, and more importantly, there's no change in mortality. So patients who have normal hemodynamics should be managed non-operatively, and one of the things that has really bailed us out over the years is angiography and embolization. So you can embolize the spleen, you can embolize the liver, maybe. You can certainly embolize the kidney. I would caution you in the use of angiography and embolization in hemodynamically normal patients with blunt liver injury because the incidence of hepatic necrosis and infection is higher than we think it is. So unless you have active contrast extravasation in a metastable patient, you probably do not want to embolize the liver. I will say the first paper I ever wrote was how important it is to embolize the liver. So welcome to 30 years of looking back. The other thing that I'll say about kidney injury is that urinary extravasation can be managed either by percutaneous drainage or endoluminal stenting. And MIS has really taken over the world. When I was a resident, we did one port surgery. It was a xiphoid to pubis port, but it was one port. I now start 80% of my cases laparoscopically. I do not ever want to dance with a robot, but that's just me. I'm an old dog. You can use thoracoscopy for hemothorax, for diaphragm repairs, for empyema. We use laparoscopy in emergency general surgery all the time to decrease adhesions, decrease pain, decrease the inflammatory response. And I think the other thing that's become really important is the recognition in the delivery of emergency general surgery care and trauma care, the multidisciplinary approach. So I mentioned our IR colleagues. I also happen to love my advanced endoscopy colleagues. And for those of you who haven't had the pleasure of dealing with pancreatic necrosis, sticking a drain in it, getting somebody to stent it with the endoscope has really saved us from miserable operations, colonic fistulas, and death. And then last but not least, in the ICU, I think we've seen the death of ARDS for the most part and abdominal compartment syndrome with the development of damage control, resuscitation, deresuscitation, i.e. getting the fluid that you gave them off, lung protective strategies, and wake-ups and sedation management. So on a personal level, less is more means learning to listen. Again, you don't need to demonstrate that you're the smartest person in the room. And then I'm going to quote my friend Karen Brazel, who says, no is a complete sentence. So learn to say no. Figure out what's important to you and invest your energies in what is important to you and let the rest of the stuff go. And I've already mentioned not adding too much value. What less is more may look like, not replaying a complication endlessly. I am a perseverator. I will wake up at 2 o'clock in the morning wondering why my patient did poorly. I'm learning to get over that. I'm 62, 63, something like that. You'll learn. Not responding to every criticism. Ending an unwinnable argument. Just say, okay, obviously in this scenario, we're going to agree to disagree. Let it go. Recognize that some people will misunderstand you, and you should allow other people to move forward with their choices. I'm a great one for giving unnecessary advice at times. It's not well received. If somebody doesn't ask you for your opinion, don't offer it. Lesson 3, ask for help. I love this picture. Every time you see a tortoise on a fence post, you know they had help getting up there. So let's talk a little bit about the types of mentors that you can have in your life, because mentors are extraordinarily important. And I love to tell the story of how I became engaged in the trauma community. My division chief was Bill Chaffee. He ultimately became the chair at Brown, where I did my residency. He dragged me or invited me to attend every single presidential dinner at the AAST from the time that I was a fourth-year resident until the time that I could take my own people because I had my own invitation. Mentors are extremely important. You can have a career mentor. You can have a technical mentor. I can still tell you which parts of how I do an operation came from which attendings taught me that skill. You can have a research mentor if you are a triple threat, or even if you're not. You can have a leadership mentor, somebody that you admire, who trains you to be a leader. My own personal favorite is peer mentorship. We're going to talk a little bit about that. I see Dr. Kokenauer in the back of the room. A stretch mentor who says, hey, what you've done is good. You can do more. This is how you can do more. A values mentor and a network mentor. And the network mentors are the ones who walk you around and introduce you to people. Mentors make your development their top priority. They help you set expectations and goals, and they help you until you can fly alone. Oftentimes, you will have different mentors for different times in your career, and that is normal and encouraged. Just remember that you need to be a successful mentee if you are asking a mentor for their time. So you need to be open and talk about what your needs are. You need to engage in the process and take action. And you need to ask questions and be open to receiving feedback. Again, you don't want to add too much value. You want to hear what people have to say and kind of stew over it for a little while. Let it inculcate into your brain. Where do you find mentors? There are former mentorship programs. East, Dr. Calcutt has a great mentorship program. Academic and business internships if you're in the business world. But remember that you can develop mentors at academic meetings. All you have to do is be willing to walk up to somebody and say, "Hi, I'm," insert name here, because you don't have to tell them that your name is. You can just say, "Hi, I'm Kim Davis." Ask them a question and engage. Mentorship is very different than coaching. And I will also say that over the course of my career, I've had multiple coaches for various reasons. Most of the time because I asked for them. When you might want a professional coach is if you're stuck and you don't know how to advance in your career, or if you have a behavior that may be negatively impacting your ability to move forward, i.e., you keep running into the same obstacles. If you're navigating a big transition, you want to go from being second in command in one shop to top of the command structure in another shop, a coach is a good person. If you want to level up, similar to what I just said, or if you want some external perspective, read here 360 evaluation and structured feedback. The one media coach that coach that I thought was extraordinarily important, particularly as we transitioned from in real life to Zoom, was learning how to be a media presence and maintain eye contact and talk in a logical fashion, and really demonstrate positive body language over a relatively artificial space. So media coaches are great. And then if you need a change or you're ready for a change, but you don't know how to get there. So mentoring is skill development. Coaching is person development. And sponsorship is totally different. Sponsorship are the people that will name your name in a room when there is an opportunity and you are not in the room with them. So these are the people that either quietly pull you along, like my friend Bill Chaffee did for me 25 years ago, or will quietly push you, but give your name to individuals so that you can build a career. So the types of coaching, again, executive coaching, which is mostly leadership presence and how to interact. It may teach you strategic planning. I'm a widget person. I'm not a strategic thinker. You can get a career coach, probably more appropriate for individuals not in medicine, but communications coaches are really important. So as I mentioned, as you transition into a chair job or whatever it is that you want to do, having a coach in how to best communicate your thoughts is useful. And then I don't know what you call your well-being coach, but I call that my personal trainer. Right? Somebody who makes sure that I show up and do things that are good for me in the hours that I'm not working. And you cannot underestimate the power of peer mentoring. And if you look at these pictures, some of them are extremely young Dr. Kokenauers. But you need to build a family of people, your tribe, for lack of a better word, where you can hang out with people and have open and honest discourse and really have a support network. So, lesson number 4, you need to understand that while you can do something, you may not always want to do it, nor should you do it. So I'm going to talk a little bit about patient-centered care and the importance of palliation. And I really believe that while we have talked about 3 legs of the acute care surgery stool as trauma, emergency general surgery, and surgical critical care, I firmly believe that we need to add a 4th leg to that stool, which is palliative care. We need to be able to talk about goals of care. We need to incorporate shared decision-making into some of the patient decisions we make. We need to have family-centered rounds, and we need to have a strong ethical framework. Because we all know that communication, particularly in an emergent setting, is difficult. You have no idea what the patient knows, understands, or wants relative to their presenting problem. You have no idea what their surrogate may know, understand, etc. You have system issues around transitions in care, and then you have the surgeon who basically thinks that nobody should die without a scar on their abdomen, which may or may not be right. And I hearken back to Ben Eisman from this panel at the American College of Surgeons in 1995. Older patients make decisions with a different database and different value judgments, such as palliation and quality of life. There are a lot of things that are worse than death to an elderly patient. And I would submit to you that there are a lot of things that are worse than death in multiple patients across an age spectrum, because survivorship without the ability to recover is not enough. So this is just a snapshot of the TQIP best practices for palliative care. Within 24 hours, an initial screen. And then at 72 hours in patients with a category 1 or 2 screen, a family meeting and a goals of care discussion. And category 1 is uncertainty due to injury severity, comorbidities, or age. Group 2 is the group that is likely to be permanently disabled or have a poor functional outcome, which is incompatible with patients' wishes. And you have to ask the surprise question. Would you be surprised if this patient were dead in 12 months? Another way to frame this is the best case, worst case scenario, talking about the best case outcomes for surgery, the worst case outcomes for surgery, and then the best case and worst case for supportive care, and giving the family time to think about it. And then my own personal favorite, and I don't have a slide on this, is if they say, oh my God, Uncle Joe would want us to do everything. Telling patients that everything may not be reasonable and that we will offer a time-limited course of therapy. We will give Uncle Joe 72 to 96 hours to reverse his multisystem organ failure, or Aunt Jane, reverse their multisystem organ failure, and then if they are not demonstrating an improving trajectory, having another discussion. So I have a lot of biases around this. I think patients and families need to understand honestly what is likely or unlikely to improve outcome. Time-limited courses of therapy, as I mentioned, are very helpful. And we need to remove the guilt around end-of-life discussions. In leadership, can versus should is very different. Leaders have the ability to discipline, reorganize. You know what reorganization means, right? 20 to 40% of the people that you work with aren't going to be there the next day. Change policy, and escalate or actually de-escalate conflict. And the question is rarely whether or not we can. It's whether or not exercising that authority produces the best outcome. Authority provides options, but judgment determines which option to choose. And we all navigate divides every day in our lives. I particularly like this picture. Just speed up, you got this. Senior versus junior faculty, traditional versus contemporary work-life priorities, EGS versus trauma, clinical versus academic, service obligations versus time for professional development, administrative resources versus what frontline clinicians need, etc. And the way to navigate divides is not to draw a line in the sand. The way to navigate divides is to build bridges. You have to assume that everybody who's in the room having a conversation with you has a shared purpose and has a positive intent. They are not out to get you. We all have a little bit of paranoia in us. You need to recognize that they are not out to get you. Again, listen before leading. Seek both and solutions. Be transparent. And if all else fails, make a decision. but rarely do you have to get to number 8. Lesson 5 is use failure as a teacher, and we're going to go back to a clinical scenario. I present to you somebody who came to me in 2025, or 2005, excuse me. 25-year-old patient, multiple thoracoabdominal injuries, liver, transverse colon, small bowel, hemodynamically unstable. Got 10 liters of crystalloid, 4 units of FFP, 2 units of 4 units of cells, 2 units of FFP, and a party pack of platelets. Had a temporary abdominal closure, a Whitman patch, and was eventually ratcheted closed on post-op day 10. Again, remember, abdominal compartment syndrome has kind of gone the way of the dodo bird for the most part. We were the first group to describe what was called the secondary abdominal compartment syndrome, which is basically developing an abdominal compartment syndrome in somebody with no intra-abdominal injuries because of the over-aggressive utilization of crystalloid. Like in life, sugar and salt are bad for you. And when you think about, and this is a hard slide to look at, but I gave you the reference. When you think about resuscitation science, resuscitation science started in 1994. So 30 years ago, we recognized that giving less volume in the field resulted in improved outcomes with no decreased mortality. It wasn't until 2007 that Holcomb came up with the idea of damage control resuscitation, limiting crystalloids, aggressive use of blood and blood products. And we've moved forward from there, now recognizing that whole blood is actually probably better than component therapy, because component therapy gives you a hemoglobin of 33, a platelet count less than 150, and a PT-INR of 1.5. So the same patient in 2024 would get less crystalloid, more blood, more FFP, and the standard party pack of platelets. The abdomen would be closed on postoperative day number 2, and the patient goes home on postoperative day number 5 with a small surgical site infection, which we wouldn't have now because we all use Aricept. So marked changes in how we manage patients because we recognize the failure of crystalloid resuscitation. And this is just the Joint Trauma Systems clinical practice guidelines saying no crystalloid, no Hextend, low titer whole blood, plasma to FFP 1:1:1, warm fluids, TXA, and calcium. So every surgeon faces failure. It is universal. We have complications. We have technical mistakes. We miss diagnoses, poor outcomes. In an academic career, you will have rejected grants, rejected manuscripts. How many of you absolutely despise reviewer number 3? Missed promotions. Failure is not evidence that you are inadequate. Failure is a reason to reevaluate and attack difficult things from a different angle. It exposes reality, it challenges assumptions, it stimulates or can stimulate innovation, it clearly identifies system weaknesses and reveals hidden opportunities. So failure is important and you should embrace it. And I love to say this to the residents: good judgment comes from from experience, and a lot of experience comes from bad judgment. Lesson 6, there is no I in team. Behind every visible success stands a network of contributors. No trauma resuscitation succeeds because of one person. No academic department thrives because of one individual. Individual talent creates potential, but teams create performance. A cohesive team can achieve extraordinary outcomes. And the highest performing organizations are not necessarily those with the smartest people in them, but they are the organizations with the best teams, the one that work together, that have trust, good communication, and a shared purpose. I've had the opportunity to be affiliated with a lot of organizations, some of which Dr. Calcutt alluded to. Each one of these organizations has exposed a different aspect of my career to me and allowed me to participate. But my greatest success is my faculty. So I am and will continue to be until I retire, a mentor and a sponsor. I have grown the program at Yale from 4 to 34 faculty. I've promoted 4 full professors, 5 associate professors. I've got 3 more people up for promotion to associate. And I've been fortunate enough to participate in the organizations that I mentioned before, but more importantly, sponsor some of my junior faculty to become regional and national leaders. So personally, I view them as my greatest success. Lesson 7, life is short, have fun. We all face headwinds, particularly now as we become increasingly corporatized. We have increased workloads. How many people know what an RVU is and what your RVU target is? Torture. You're lucky you're in a shared service model and you are a shift-based employee rather than an RVU employee. We have decreasing reimbursement. We have more underfunded patients, declining margin in the hospital, older and sicker patients. People are fairly entitled. I know that'll surprise you. And then I already alluded to the rapid increases in medical knowledge and technology. So we have a burnout rate of about 40%. So what can you do to have career longevity, i.e. avoid burnout? Karen Brazel, no is a complete sentence. Learn to say no. Do what is important to you and not anything else. Define your work hours. Be very deliberate on your calendars when you become an attending to mark out those times when you have to go to the doctor, when you need to do something that is important to your family. If you need a block of academic time, put a block on your calendar so that nobody violates it and you can have the time that you need. Prioritize recovery. It gets harder and harder to take overnight call as you get older and older, so don't take every other night, for example. Have a support network and maintain your health. Oftentimes we take a break when we are totally empty. I would like to encourage you to take a break when your tank is at about 2/3. Life is short, have fun, it boosts well-being, it strengthens relationships, it sparks creativity. It keeps this job in perspective because this is a hard job that we do. It fuels performance, and then if you're lucky, you'll have a couple of fun stories to tell. So last but not least, breathe. These are pictures from Dr. Kokenauer and my most recent trip to the Arctic, where we saw polar bears and walruses, or as one of my friends says, walrus, multiple types of seals, and just had an incredible experience. So take time for yourself and breathe. I hope this has been helpful. Happy to take any questions. And again, thank you very much, not only for the invitation, but for the opportunity to come and speak with you today.